Welcome to the OMM-medicine's module on kidney stones. So there are several different types of kidney stones which you can see listed here and that we will cover throughout the entirety of this video. And the presentation for all of these is typically going to be similar. We'll have some degree of flank or abdominal pain, and we can also have hematuria depending on the type and size of the stone. The diagnosis of a kidney stone is going to be similar regardless of the type of stone that it is, and it will have largely two components: a history and physical component, and then our imaging, which is typically going to be a CT without contrast. Now, a urinalysis and other urine studies may also be performed. However, they are not typically going to be diagnostic of a kidney stone in of itself. That's typically going to be seen on imaging, and that's the major way you'll diagnose a kidney stone. However, on urinalysis, the common finding that you'll see in a patient with a kidney stone is going to be hematuria. So the first type of stone we'll talk about are calcium stones, and these are going to be the most common type of kidney stone. And there are two subtypes of calcium stones. These are going to be calcium phosphate and calcium oxalate. When we look at calcium stones under a microscope, they're classically described as having an envelope or a dumbbell shape, and these are two very common buzzwords for your board exams. And there are many triggers that you need to be aware of that can precipitate a calcium stone. So one of the major risk factors for the formation of a calcium stone is going to be alkaline urine, or urine that has a basic pH. High oxalate levels, which can be seen in patients with Crohn's disease or after gastric bypass surgery, is also a risk factor for calcium stone formation. The ingestion of ethylene glycol or antifreeze is a very commonly tested risk factor for the development of calcium stones. Vitamin C abuse and then high calcium levels in the urine or in the blood is also going to be a risk factor for the formation of calcium stones. Now we will talk about some of the important dietary changes that are suggested for patients with a history of calcium stones, and this is a very commonly tested subject, so it's very important to understand both the physiology as well as the information listed on this slide. Now there's a common misconception that if you have a history of calcium kidney stones that you should decrease the amount of dietary calcium that you eat, and this is simply not true. The only reason that you should decrease the amount of calcium that you are taking is if you are already taking more than the suggested amount. If you are taking in the normal amount of calcium, there is no indication to decrease the amount of calcium that you eat. Now, perhaps the most important dietary change you can make to prevent kidney stones is to increase the amount of water you drink, and you typically want that amount to be greater than 2 liters of water a day. Other substances to increase your intake of for the prevention of calcium stones would be citrate or potassium citrate, and then potassium as well. Now, there are also several substances you want to decrease or limit your intake of, and one of the most important and most commonly tested substances is going to be sodium. So you want to limit your sodium intake to less than 2,300 milligrams a day. You will also want to decrease the amount of animal protein you eat. And then to decrease your risk for calcium oxalate stones specifically, you'll want to decrease your amount of intake of oxalate, which is commonly found in green leafy vegetables like spinach. And I just want to reiterate two major points from this slide because they're very commonly tested and very high yield. The first is for the prevention of kidney stones, we want to increase the amount of fluids we intake. And the second is that the decrease in the amount of sodium intake and not the decrease in the amount of calcium intake will help for the prevention of calcium stone formation. So if we have a patient who has kidney stones, how do we go about managing that? Well, the first is going to be with dietary modifications. As we previously mentioned, we want to increase the amount of fluids that we intake and decrease the amount of sodium that we intake. The second line for the management of kidney stones after simple dietary modification is going to be thiazide diuretics, the supplementation of citrate, and then shockwave lithotripsy if the above options have not already worked. And obviously, if all else fails, surgical intervention can be used to help relieve the kidney stone. And I wanted to include this clinical pearl here at the bottom for the management of kidney stones by size. So if a kidney stone is less than 5 millimeters, these are very small. They'll typically pass spontaneously with a little bit of time and with increased fluid intake. For stones that are between 5 and 10 millimeters, alpha-1 blockers like tamsulosin can be used, and then you can reevaluate the patient in a couple days to see if the stone has passed on its own. And this is going to be done again in addition to increasing the fluid intake for the patient. And finally, for stones that are greater than 10 millimeters, centimeters. These are going to be very large stones and will typically have other complications like obstruction, and so a urology referral should be put in for patients who have a stone of this size, because invasive management is likely going to be needed because they will typically not pass on their own. Now, the next type of stone we'll talk about are called Struvite stones, also called Ammonia-magnesium-phosphate stones, because that is what they are composed of. And these stones are commonly going to be a result of infection in the urinary tract, commonly with urease positive organisms. So these are going to be bugs like Proteus, Staph, and Klebsiella. And just like we saw with the calcium stones, an alkaline urine or a basic urine pH is going to also be a risk factor for the formation of a struvite stone. Now, these stones are radio-opaque, meaning that we should be able to see them on a regular x-ray. And a very important buzzword for your boards is that when we are going to look at struvite stones under a microscope, they are classically described as having a coffin lid shape. One of the most important points about struvite stones is that they can form something called a staghorn calculi or staghorn calculus, and this is essentially a very large stone that takes up a very big part of the kidney, and these are going to require surgery to resolve because they will grow to be so large that they cannot pass on their own, and they will cause many other complications like obstruction and possibly pyelonephritis. And finally, the management of a struvite stone is the same as the management for the calcium stones, as we just spoke about. However, we will also want to add antibiotics for a struvite stone because remember, they are going to be caused by these urease positive organisms. So we want to kill whatever bug was the cause of the stone to begin with. And then if the stone has formed into a staghorn calculus, we will also need surgical intervention to remove the large staghorn calculi. The next type of stone we'll talk about are uric acid stones, which, as their name implies, are simply made out of uric acid. And these stones are going to be formed when the amount of uric acid in the urine is high. So we should ask ourselves, in what scenarios or conditions would we expect high levels of uric acid in the urine? So patients with gout, leukemia, myeloproliferative disorders, maybe a history of tumor lysis syndrome after chemotherapy, they would all have high levels of uric acid in the blood, and therefore you would expect higher levels of uric acid in the urine as well. Now, uric acid, as the name implies, is indeed an acid, so if we have acidic urine, then we will also have an increased risk of the formation of uric acid stones. So once again, we need to ask ourselves, why would we expect someone's urine to be more acidic than normal? And the two most common conditions or scenarios in which we would see this is going to be patients who have chronic diarrhea and patients who live in hot climates. And we should also point out the correlation to where these stones are typically formed within the nephron itself. And if you remember back to physiology, the distal tubule and collecting duct are going to be the most acidic urine that you have, and therefore the uric stones are going to be more likely to form in these two areas of the nephron. Now, these stones are radiolucent, meaning we would not expect to see them on a regular x-ray. They are classically described as having a rhomboid or rosette shape, and the management for uric acid stones is going to be the same as it is for all other types of kidney stones. However, we can also consider the use of potassium bicarb, as this will increase the pH or alkalize the urine, which will help decrease the formation of these acidic stones. Now, I've also included that allopurinol is typically not going to be used for the management of uric acid stones. However, it can be if all the other options fails. However, for your exams and your board exams, it's important that allopurinol is not going to be the first line for the management of a uric acid stone. And I want to point out two major differences between the uric acid stones and the calcium and struvite stones, which we've already discussed. And the first is that uric acid stones will form in increasingly acidic urine, whereas the calcium and struvite stones formed in more alkaline or basic urine. And the second is that uric acid stones are radiolucent, and they typically should not be seen on a regular x-ray, whereas the struvite and calcium stones were radio-opaque and typically could be seen on a regular x-ray. And the last type of stone we'll talk about is a cystine stone, which is a much rarer form of kidney stone and is typically only seen in children who have a history of cystinuria, which is the condition in which you cannot absorb cystine. So these stones are going to have a hexagonal structure, where they'll have 6 sides. They're typically going to be formed in acidic urine, just as we saw with the uric acid stones. And then these can also form staghorn calculi, just like we saw with struvite stones. And the treatment for cystine stones is similar to all other kidney stones, We want to increase the amount of fluids that we drink, and then we also want to alkalize the urine just like we did for uric acid stones, because cystine stones are also going to be formed in acidic urine. And the major defining feature of cystine stones outside of their hexagonal shape is going to be that they're seen in children. Other types of kidney stones are not as commonly seen in children. They're typically going to be in adults. So if you see a kidney stone in a young child, you should really have a high suspicion that it is a cystine stone and that this patient may have cystinuria. And that brings us to the end of this module on kidney stones.